Thank you so much for inviting me to talk today about weight management. My title is Weight Management, the Art and Science of Empowerment. So the objectives today is we're going to identify obesity as chronic disease and not character flaw. We recognize the bias against people suffering from obesity, even in the medical society. We'll talk about the role of clinical practitioner in fighting obesity and the role of society as well in fighting obesity. In terms of agenda, we'll start with the burden of obesity in our population. We'll talk about introduction to metabolism and physiology, why we gain weight, and how can we make difference. And then we'll talk about our approach in our office, in our center. So what's obesity? Obesity is defined by the World Health Organization as abnormal or excessive fat accumulation or adiposity in the body that may impair health. I like Obesity Medicine Association definition, which is more involving and more explaining. It's defined as chronic, relapsing, multifactorial, and neurobehavioral disease where an increase in body fat promotes tissue dysfunction and abnormal physical stress to the body because of the fat mass. This causes metabolic, biomechanical, and psychosocial health consequences. So adiposity and obesity can be measured in different ways. The most easy one is body mass index, where overweight starts from 25 to 29.9, and obesity starts at BMI above 30 and classified into different classes, depends on how high it is. Other ways to measure adiposity is the body fat, and we have different ways of measuring that, including bioimpedance or DEXA scan. And what's considered at risk is for women with fat percentage more than 32 and for men more than 25. So the burden of overweight and obesity in Canada is 64 to 70% of people have BMI above 25 and considered overweight. And about 40% of people are even obese. And obesity has been increasing substantially over the last years and started to increase specifically around the 70s and 80s, and likely as we started increasing our consumption of refined carbohydrates and sugar. Well, does obesity affect mortality? So if we look at this slide, this is on the x-axis, we have the BMI, and we see the lowest mortality is in this group where BMI is 20 to 25, and the mortality increase with each 5 units in BMI by 30%. So when BMI is 25 to 30, there is decrease in life expectancy by 2 to 3 years. When we reach 30 to 35%, 30 to 35 BMI, we can see a reduction in life expectancy by 4 years. And at 40 to 45%, there is even increase in life expectancy by 8 or 10 years. And this is equal to people who smoke. So definitely obesity has significant increase in mortality. So what are the diseases that we can associate with adiposity? So if we divide it into systems or organs in terms of pulmonary, we see hypoventilation, obstructive sleep apnea, asthma. If we look at the skin, we can notice increase in hirsutism, psoriasis. When we look at the GI system, the gallstones, non-alcoholic fatty liver, even colon cancer, GERD, esophageal cancer. There's decrease in fertility and risk of cancer of the uterus, breast, cervix. For CNS, we see increase in migraine, headache, stroke, and even dementia. We see increase in ischemic heart disease and heart failure and thromboembolism. We see increase in hypogonadism and prostate cancer. And of course, we see increase in joint pain, osteoarthritis, gout, and diabetes, dyslipidemia. So let's switch the gears a little bit and talk about physiology. What is controlling our weight? So let's understand the basics. We often see this scheme here where body weight is on a scale and we see energy in and energy out. And it's simplified as, you know, if we gain weight, if we take more energy in than we burn out. So basically, from one end, we have the carbs, protein, and fat in and out, what we burn in resting metabolic rate, what we burn in physical activity, and what we burn to digest food, something known as thermal effect of feeding. So again, if our intake is more than our output, we gain weight. However, is it that too simple? Actually, in reality, this is what looks like controlling our weight in the body. It's way more complicated. And if anything, it looks like this busy net of highways in very big city. So if we want to zoom in, the arcuate nucleus, which is here under the, it's part of the hypothalamus. This area of the brain takes signals from the GI and adipocytes hormone, takes signals from our nutrition sources like glucose, fatty acids, and amino acids. And here we see two kind of neuron systems, the POMC-CART system, which promote weight loss. And on the other hand, we see the NPY neurons that promotes weight gain. And these interacting two pathways control if we gain weight or lose weight. If we look at what's in the periphery, there are a lot of hormones that control our appetite and energy expenditure. In the stomach, we have the ghrelin, which increase our appetite and decrease our energy expenditure. And on the other side, we have a lot of hormones from the small intestines, large intestines, as well as the pancreas, which promote weight loss and increase energy expenditure. So we'll talk about some of these hormones. The ghrelin, it's produced from the gastric fundus and body. It's secreted when the stomach is empty and serves to initiate eating and decrease energy expenditure. The level increase with fasting to increase the hunger, and it decrease after meal ingestion as the stomach is stretched, causing a ghrelin secretion to drop and decreasing the hunger. So in simple, it is the hunger hormone. When it is elevated, it causes hunger, increase appetite, and when it is lower, decrease the appetite and the energy expenditure. In terms of the small intestine hormones, these are hormones secreted from the intestine to help meal termination. These hormones are circulate in the CNS and vagal afferent neurons to cause anorexic effect, and this is short-acting. So in brief, it is the role is meal termination. And these hormones, the most important one is GLP-1, which we'll take as example and zoom in a little bit more. So this is secreted in response to carbohydrate ingestion. It causes a glucose-dependent insulin secretion, and it restored the first phase insulin. And that's why it does not cause hypoglycemia, because it only causes secretion of insulin when food is available. It also reduces the hepatic gluconeogenesis by suppressing the glucagon, and delay the gastric emptying, increasing the satiety, and by then decreasing the appetite and reducing the weight. And the last hormone we're going to talk about is what comes from the adipocyte hormone, leptin. And as we know that a few other hormones are secreted, including adiponectin and other inflammatory cytokines. Leptin, for our concern today, it causes weight loss, fullness, and satiety. So actually, leptin and ghrelin have counterbalancing effect on energy balance. So if we look here, the leptin will cause stimulation of POMC neurons, causing weight loss. It causes decrease in the neurons in PY's neuron system, causing again anorexic effect. On the other side, ghrelin has the exact opposite. It suppresses the POMC and stimulates the NPY neurons. So this is nice schedule of differences in terms of timing. Leptin reflects long-term energy balance, while the ghrelin is respond to acute hunger. The site of action, they both work on the hypothalamus, and we said what's activate them and what inhibits them. So again, if we look at the pathophysiology again to this scheme here, we have all these hormones here causing weight loss, decreasing the appetite and increasing the energy expenditure. And we have only one hormone here causing increased appetite and decrease energy expenditure. So the question is, if we have all these hormones trying to prevent weight gain, why do we gain the weight? Well, in the 1940s, a Dutch scientist named Nico Tinbergen performed a series of experiences, and he won Nobel Prize for his work. So Tinbergen investigates herring gulls, where the adult birds have a small red dot on their beak. Tinbergen noticed that the newly hatched chicks would pick this spot whenever they wanted food. So Tinbergen went ahead and created a fake dummy mother with big red dots. And he was surprised to notice that the bigger the red dots, the more the chicks will pick. Well, humans are prone to fall for exaggerated version of reality too. And if we look at the social media, we often see pictures of people in their best version, and sometimes we don't know what reality is really all about. Okay, let's go back to food. As a matter of fact, junk food drives our reward system into frenzy, and millions of dollars are spent to discover the most satisfying level of crunch in a potato chip or the perfect amount of fizz in a soda. An entire department are dedicated to optimize how the product feels in our mouth, a quality known as oral sensation. Other processed food enhance dynamic contrast, reflecting or referring to items with combination of sensation like crunchy and creamy. Imagine the Oreo, where the outside is crunchy and the center is smooth and creamy. With natural unprocessed food, we tend to experience the same sensation over and over. And after a few minutes, our brain loses interest. and we feel full. But foods that are high in dynamic contrast, they keep the experience novel and interesting, encouraging us to eat more and more. Food scientists now are able to find the bliss point for each product, the precise combination of salt, sugar, and fat that excites our brain and keep us coming back for more and more. And the results, of course, we overeat and we gain weight. We really have gotten too good at pushing our own buttons, as a scientist, neuroscientist specialized in eating behavioral and obesity, Stephen Gwent. So back to this scheme again, and we see just the proximity of the arcuate nucleus and the reward center, we can totally understand why there is the reward center, why it is stimulated by those high palatable food. So again, back to our scheme that, on this side, ghrelin increased the appetite and every other hormone decreased the appetite. Why we end up overeating? Well, our decision to eat can be overridden. Even with this stringent control, our emotions can affect the way we eat, our palatable food, the social events we go to, the reward, the motivation, and the memories. So why obesity is chronic disease? Well, let's think about what happens when we lose weight. So if we divide the centers controlling our weight into three areas, at the lowest point is the hypothalamus, where it looked like this lady sitting or standing at the gate of hunger or starvation, monitoring the level of leptin. And as we remember, leptin is the hormone that's secreted from the fat cells. So when we lose weight, there is decrease in the leptin, and this lady will panic as it is signal for hunger and starvation. So what it will do, it will set the alarm to the higher level of this, where our memories of food and anything associated with food is stored. So it will look like Tarzan looking for food, and when it see the cue, it will send the signal of craving up. And the reason this signal is captured that way, like wave, because different from hunger, it dissipated away if we ignore it. Well, still it needs the order to come from the frontal lobe, the executive, which is usually busy. And by the end of the day, when we're tired, more decisions goes to the autopilot, and we get our permission thought to eat unhealthy food. So how is that translated? Well, our body will keep trying to keep us at the highest weight achieved. Weight loss journey is not a marathon that we win when we cross the finish line. And quick crush diets are set up for failure by design. And really the key is sustainable, maintainable lifestyle changes. So how can we make a difference? Well, changes is strongly influenced by interpersonal interaction, and our words, our behavior, our emotions can go long away with our patients. So if we look at one side, what control our weight, there is genetic, family history, ethnicity. On the other side, there is lifestyle, culture, physical activity, diet, and stress. So these we can control, and we call it habits or behavior. On the other side, genetics, family history, and ethnicity obviously are not modifiable. So how to change behavior? Sometimes, often we use scary tactics, and does it work? Sometimes we see those graphic pictures of, quit smoking or suicide by sugar, but does it work? Well, this study say that humans show natural tendency to discount bad news while incorporating good news into beliefs. And that can explain seemingly irrational risk-taking in some people. Well, that's exactly what happens when we face a danger. Most likely we go for freeze, flee, and we rarely fight. So why changing habits is difficult? We often focus on the wrong things. We often focus on the goals that we want to achieve rather than the process or the system that leads to these changes. We focus on the behavior rather than the mindset. We focus on the habits we want to change rather than who you want to be. So why changing his habits is difficult, or what is different? So what's the difference? Goals are about the results you want to achieve, while the system are about the process that leads to these results. Goals are good for setting directions, while the system are best of making the progress. The purpose of setting goals is to win the game. However, the purpose of building the system is to continue playing the game. And I like this quote a lot. You don't rise to the level of your goal, but you fall to the level of your system. So if we think about behavioral change, if we think about the outcome, so when we focus on the outcome, we focus on the results, such as losing weight or winning a championship. At the lower level, we have the process where we focus on changing the habits and the system, such as implementing a new routine at the gym. But at the deeper level and the core, we have the identity, where we change the worldview of ourselves and our judgment about others. And most of the belief, assumption, and bias are held at this level. So in our center, patients sometimes feel weird when I ask them why you want to lose weight. And when they tell me like, well, because I want to feel happy, or I want to be able to play sport. I like to go more deep into like what happy means to you, what happy looks to you, and what kind of sport, what do you like to do? So often we hear patients later on when we go deeper talking about, I want to lose weight to improve my diabetes control. I like to travel without special seating accommodations. I would love to keep up running after my grandchildren. Or I am sick of wearing this XX sizes. So the deeper we go into core value, the better we achieve and sustain the change. So remember, people do not lack motivation, they lack clarity. And our role is to make it clear what they really want. We often work with positive image in our clinic rather than putting a clear mirror. In our center, we talk about the values and we dig deep to get a core values that we can build on lifestyle, cognitive behavioral therapy, dietary changes, physical activity, pharmacotherapy if we need to add to, or even meal replacement. And we call our approach holistic. How can we help as medical providers? Well, we should be aware of bias against patients with obesity. And that starts from the waiting room, the magazine that we choose, and the seating we pick. Providing appropriate scales for these patients. Providers should be aware of medications that promote weight gain, such as for diabetes, insulin, sulfonylurea, and TZDs, and try to see if there is any room to improve this regimen to include medication that promotes weight loss, such as GLP-1, SGLT2, and metformin. When it comes to beta blockers, when it comes to hypertension, beta blockers are known to cause weight gain, and the more specific the beta blocker, the least weight gain. So when we choose a antihypertensive, calcium channel blocker and ACE inhibitors, or even ARB, will have way less or even no effect on weight gain. And the big issue with medications are antipsychotics. And I like this. I go often to this graph to choose the one that has the least weight gain. How about pharmacotherapy? How do we treat obesity with medications? So we have 3 medications approved by Health Canada. Orlistat was approved in 1999. Liraglutide or Saxenda was approved in 2010, and Contrave was approved in 2014. So Orlistat works by inhibiting the pancreatic lipase, blocking the fat absorption by 30%. What we need to monitor in this medication is making sure that patient will not have fat-soluble vitamins deficiency such as A, D, E, and K, and also potential interaction because of lack of absorption of other medications such as the thyroid and warfarin and oral contraceptives. Benefit of this medication with patient with hypercholesterolemia, it causes improvement. Side effects, contraindication are gallstones and chronic malabsorption syndromes. Side effects commonly cause oily rectal discharges, diarrhea, bloating, and kidney stones and gallstones, of course, as well as the fat-soluble vitamin deficiency. When it comes to GLP-1, liraglutide is available. The mechanism of action is it's glucagon-like a peptide-1 receptor agonist. It activates specific area in the hypothalamus, causing decreased food intake and decreasing appetite, increased satiety, decreased weight. It slows the gastric emptying and improve glucose metabolism. In terms of dosing, we escalate the dose starting from 0.6 to 1.2 in the second week, third week 1.8, as much as tolerated up to 3. And sometimes we go much slower if the patient have intolerance. And usually if you wait enough, most people will tolerate a reasonable effective dose. In terms of Contrave, Contrave works by accelerating the POMC neuron firing, causing reducing weight and increasing energy expenditure. It's a combination of 2 medication, naltrexone, which is opiate antagonist. So it works on the hypothalamus and mesolimbic dopamine reward circuit. It helps control the craving and food addiction. And the bupropion, which is reuptake inhibitor of dopamine and norepinephrine, works on the hypothalamus as well and the mesolimbic hunger center and decrease the appetite. In terms of dosing, start with 1 pill in the morning first week. Then next week, increase it to 1 pill in the morning and 1 pill in the evening. Third week, 2 pill in the morning and 1 pill in the evening. Fourth week, 2 and 2. Interaction, you need to avoid high-fat diets, and bupropion can increase the chance of seizure for patients who have issues with seizures. Drug interaction, also need to avoid opioid use 7 or 10 days before starting, and also monoamino oxidase inhibitors should be held for 14 days prior to start. Benefits of this medication, it helps the excessive hunger and craving, and in patient who smokes, they are less likely to continue smoking. Contraindication, pregnancy, lactation, seizure, uncontrolled hypertension, uncontrolled migraine, anorexia nervosa or bulimia, major anxiety disorder, bipolar disorders, and alcohol and some others, phenobarbital and opioid. In terms of side effects, neuropsychiatric symptoms, suicidal thoughts, as well with all other antidepressants. Common side effects is nausea and headache. Beside that, it is very well tolerated. So what is our role as society? Well, I call it becoming socially responsible. So as a parent, be aware of your children's risk of obesity and avoid junk food and soft beverages and juices. As a teacher, avoid rewarding with sweet and dessert. As a grandparent, avoid sweet treats and express love in quality time. When inviting others, provide no more than 2 main dishes and avoid soft drinks and juices. And in picnic, drink water. Again, avoid soft drinks and juices. And we all know this commonly quoted proverb, it takes a village to raise a child, but it takes a whole society to fight obesity. And thank you.